Hi, everyone. Welcome to the conference session titled Transplantation Overview. Thank you for joining us today. My name is Nyari Sireo, Patient and Professional Programs Coordinator. As we get started, AMDSIF would like to recognize the generosity of our corporate sponsors. At the diamond level, we have Alexion and Novartis. At the gold level, we have Apellis and Genentech. And we would also like to thank our generous support from our patients, families, and caregivers for supporting our conference today. Immediately following the session, there will be a question and answer session. When asking questions, please say it out loud so that everyone in the room can hear the question. I also ask that you do not share any private health information in your question, as our speaker cannot answer any specific questions related to your healthcare. Today's specialist is Dr. Ryotaro Nakamura. Dr. Nakamura serves as the director of the Center for Stem Cell Transplantation and is the Jan and Mace Siegel Professor in Hematology and Hematopoietic Cell Transplantation. He has been at the forefront of leading edge research in stem cell transplantation with the focus in immune reconstitution, graft versus host disease, GVHD. His clinical and research expertise extend to leukemia, bone marrow failure syndrome, including aplastic anemia, myelodysplastic syndrome, MDS, and other rare bone marrow failure disease such as paroxysmal nocturnal hemoglobinuria, PNH, and large granular lymphocyte disease, LGL. With that said, it is my pleasure to welcome Dr. Nakamura.
Yes, thank you so much for a very generous introduction, and thank you for joining us today. As I spoke this morning, really appreciate your coming to our campus and spending whole day learning, but also teaching us about your own stories. Now, I think there was one missed instruction about today's events that this morning we found. I mean, you see a lot of small animals around this campus, and we saw an opossum sneaking into the facility. Actually, it was cute, and we guided him out. But I think we are not supposed to feed them or pet them, or not to be bitten. Okay, so that's a forgotten instructions for the day. So actually, I'm supposed to unmute. Or this is unmuted, I guess. Yeah. Okay. Thank you. So so these are my disclosures. It's not the CME, but I do work with some of the industry partners for research, clinical projects. And my talk, so the transplantation can have a lot of information regarding methods, how to do it. But my talk's gonna mainly focus on who and when. So the indication of transplantation, focused on MDS and aplastic anemia today. I'm gonna touch upon a few aspects of how to transplants, including some of the donor-related issues, conditioning regimens, which are the regimens that we give prior to transplants. The GVHD, my colleague, Dr. Sandy, will be talking later in this afternoon, so not going to too much. And there are some elements of supportive care rate effects that are part of the transplants. Dr. Reese here to talk about on that topic, as well as in the other side, side of the auditorium. My colleagues are also talking about symptom management, supportive care as well. So, we'll start with what allogeneic transplantation is about, and it is the only potentially curative treatment for many of the blood disorders and blood cancers by eliminating the cancer type malignant hematopoietic clones through this chemoradiotherapy that we provide prior to the infusion, but more importantly, the very potent immune effect, so-called graft versus leukemia effect, where the donor's immune cells can see the cancer cells or MDS cells as enemy and can fight off to cure the disease. And also by having healthy blood stem cells, you can restore blood white cells, red cells, and platelets in time. And however, this is associated with major risks of mortality, morbidities, often because of these beneficial effects of immune interactions, delayed recovery of the immune functions, chemotherapy, radiotherapy related toxicities. It is rare, but the graft failures still can happen as well. And I think many of you are probably know how it is done, or I know actually some of you are the survivors of transplantation. It's not the surgery, but takes stem cells from either blood or from the bone marrow from a donor and infuse to patients over 1 hour or two. Not very much different from the ways that the blood transfusions are done. And one thing I really like to emphasize is that it's not a prescription, it's not the procedure really. It is a process that takes weeks and weeks and months in many cases, where the infusion of the cells again takes only an hour or two, but the process of those cells start to engraft, grow inside, both producing white cells, red cell platelets, but also recover the immune cells, immune system rather, from the original donor to protect you from infections and also to fight off any leukemia or MDS cells. And the different time course, different complications can arise. Um, um, due to conditioning regimens. For example, nausea can be immediate, but hair loss could be a couple of weeks later that happens. Infusion of the stem cells relatively smooth, but after the infusion, we often say 100 days or 1 year that the infections, or this called graft versus host disease, which is due to these interactions between the donor's immune system and the host, the patient's own tissue, that can create some inflammations and damage to the organs as well. Now, also in principle, how we discuss transplant or not to do transplants, I think requires some understanding, basic knowledge about what the natural history of disease may be. What happens if you don't do any treatment, or if you do treatments, and how we can change that prognosis or expected course by offering chemotherapy or stem cell transplantation. We also have to kind of know how the transplant works for each given disease. And then you could kind of estimate the risk of not doing versus risk of doing transplantation, and see if doing it makes sense. Often it's a little hard choice when we have maybe benefit margin, when maybe that benefit is maybe 5% or so, and how much of the benefit margin you have to justify going through potentially life-threatening therapeutic options. So we'll use MDS and aplastic anemia as an example, and we'll try to take you through. Now, we heard about MDS this morning already, so I'm not going to repeat. It is a disease or syndrome, rather, associated with three usually distinct features of low blood counts, number one. Number two, dysplastic morphology, meaning the cells under the microscope look strange and funny in shape and size. And the clonal disorder, so that's a kind of cancer type biology background that this disease has the tendency to evolve into acute leukemia. So to make the diagnosis of MDS, you typically have to have three components together as a syndrome. And we also heard today about how the MDS behaves and what kind of factors affect on the well-being or the prognosis of each patient, based upon the simple factors that we talked about, blood counts. I mean, basically, all comes down to this: that the blood counts, percentage of the blasts, and some, cancer type biology is represented by chromosome or the molecular mutation. Now, the most advanced way of identifying who is at risk for more immediate risk. Now, there have been many, I think, drugs, chemotherapies are used in, decades ago to improve upon MDS, but the only after so-called hypomethylating agents became available, the natural history improved. As shown here, that the people who are on the azacitidine arm survived longer and better. Progression to leukemia was delayed, but not forever. So if you look at the span of improvement, it is around a year or year plus that this drug can kind of sustain a response. And if you look at the outcomes from many of the studies that were done, phase 3 trials comparing azacitidine or decitabine versus non-HMA therapies, best supportive care. I mean, after 2 years, 3 years, people who are surviving are very dismal, somewhere between 10, 15% up to 20, 30%. Especially for those who stopped responding or did not respond to azacitidine, their prognosis has been shown to be extremely poor. Except again, this is a retrospective study and more than 10 years ago, so that the people who are well enough to have a transplant, their outcomes seem to be more favorable. In terms of how the transplant is performing, the field is making progress a little by little, and again, the survival curves you look at, from the centers in the U.S., the most recent era, 16 to 18. The more people are succeeding with these procedures, not far from 100%, of course, but again, seemingly better than what's shown in before in terms of survival after azacitidine alone. Now, the number of transplant is also increasing, so not just outcomes slowly getting better, exponentially really, especially older adults, transplantation has been much more commonly offered. However, I don't know if you follow the news or some sort of insurance type information, but the Centers for Medicare and Medicaid Services, CMS, we called, in 2010 issued a decision memo stating that they don't really have enough evidence that the transplant is going to help their beneficiaries. So they decided not to cover the cost of transplantation back then. But they did offer the program, so-called the coverage with evidence development. So only those patients, if they are under the Medicare, so 65 above, that are participating in clinical trials that are trying to address the question of how the transplant are going to help those patients with MDS, then you'll be covered. So every single case had to be on the studies that would address their questions. And we had two of them, so-called BMTC 1011-2 and a CIBMTL study, which is a registration study. And I'll go through some of this data today. Now, this is a slide that I made in a conference in Las Vegas, and I didn't have to disclose how much I gained or lost. But I thought, when we are dealing with a very strong a card by the dealer, right? King showing, and we don't know what else. And we feel like we are squeezed, oppressed to do, something. Now, if you have, 16, I mean, the chance of going bust is pretty high, but statistically speaking, you have to call for a card. And all these calculations here, when to bet or when to ask for more card or when to stop. Now, the similar kind of mathematical models been developed in MDS to see when the transplant makes sense. And this is one of the earlier studies that are demonstrating, IPSS. Early stage, they did not really benefit from the transplant early on. Only those who are advanced stage had, again, statistically or mathematically had the benefits. This was all, young patients, bone marrow graft, ablative conditioning. The second study did the same thing, but more focused on the older adults, reduced intensity transplants, but the results are very similar to say that this IPSS intermediate 2 or high. So the higher two groups had the benefit of transplantation in the quality adjusted life expectancy, whereas the low risk wasn't. So there are some statistical models that guided us when to do a transplant. And also the this CMS questions of, if in fact, older adults do worse than the younger people. There was a report a couple of years ago from the Center for International Blood and Marrow Transplant Registry, comparing the transplant outcomes between 55 to 64-year-old versus 65 above. And there wasn't really a visible, detectable difference between. So this was used as actually evidence to support Medicare coverage later on. The direct evidence is coming from so-called biologic assignment study. So you can't really do a randomized and blinded study for patients who are ready to do a transplant and then tell them, okay, coin flip, you don't go transplant. You get like a placebo cell infusion and take a placebo cyclospor. I mean, just that doesn't happen. So the only way we could do was to decide on the transplant or not transplant based upon a donor available or not. But you have to register those patients before we know if the patient has a donor or not. So the European did a couple of studies. This is from French group showing that the people who found the donor survived better, but in the beginning, the difference was not so obvious. The German group took all these newly diagnosed cases. So this was kind of combined study upfront by DESA or azacitidine, and people who had the donor, matched donor, could proceed with a transplant as planned, and who did not have a donor, continued on the drug, and you see the survival difference in this way. In the US, we did take more robust study designs and larger patient populations, but focused on de novo primary MDS, IPSS, R intermediate. IPSS actually, not the R, intermediate to a high risk, and age 50 to 75, and the same way that we register and start searching for a donor. If we found the donor, consider donor arm and supposed to go for transplantation. And this study did clearly demonstrate the improvement of survival for patients who could go to transplant because they had a donor versus not finding a donor and therefore could not go for transplant. Now I'll talk a little more about the different type of donors, and nowadays we could offer transplant with mismatched donors or half-match family donors. So we cannot really do this kind of studies anymore. But again, years ago, the outcome of those mismatched donor was very poor, similar to the ones that I showed you without the transplant, just by this alone. Physicians followed the protocol. And one of the important findings was that the benefit of transplant versus non-transplant was visible, seen in the group of patients who are 65 year below, so 50 to 65 versus 65 above, no difference. The median age of this study was 67-year-old. And this is a leukemia-free survival, similar results. And we did look into the quality of life. So there's a myth about transplantation that transplant can result in something miserable side effects, pain or nausea that goes on for months and months, years and years. GVHD, I mean, all the sort of associated complications might make their quality of life lower than otherwise. Now, when we studied, these two groups, we saw no difference in all the different kind of measurements of their well-being between people who had the donor and the transplant versus people who stayed on the non-transplant therapeutic. Another myth that is often discussed in the community, the transplant community, is that there are some very difficult to treat MDS, often associated with a mutation called TP53 gene mutations. And again, I think you've heard some of these in the talks this morning. And some of these studies did show the outcome of a transplant, even with a transplant, that this MDS is so bad that maybe we should not be doing transplant to begin with. But when we looked at the mutations in this trial, we showed even here it is that even with a mutation available. Okay, so I take back. I'm sorry. So it's true that when you have a TP53 mutation, the results are not as good as otherwise. That remains true. But between the people who had the transplant versus no transplant, still the transplant is offering some benefit on survival. And so City of Pope, at least we have been offering a transplantation for P53 mutated MDS. And in fact, earlier on, actually, our colleague, Dr. Aldos, and we studied the mutations on so-called therapy-related MDS, which is particularly high-risk MDS that develops after previous exposure to chemotherapy, breast cancers. And we did not really see a difference in outcome after transplant between those cancer-related MDS versus, the novel new MDS. Or if they had the P53 mutations or not, wasn't really affecting the outcome. So still, I think area of research to be done. So in summary, among higher risk MDS patients, having a donor was beneficial, and Medicare beneficiaries had no sort of different outcomes, compared to those who are younger than 65. Quality of life not impaired, and still benefit exists for super high risk MDS as well. So the message I think we are going to make is really to have early referrals and discussions, whether to do a transplant or not is a second step. But we like to have those patients, coming to us for discussion. Now, I'll talk about how to transplant in a minute, but before we go there, I'm supposed to talk about aplastic anemia as well. So, so this is the first case report in 1888 from Germany, Dr. Eric, describing a case of anemia with, lack of bone marrow cells inside. Later on, actually, a French group reported the second case and came up with aplastic anemia as a name. Now, as I mentioned, you really have to know what the natural history is to talk about the transplant, because what the transplant would do to improve it. And these are the data back in 70s when we had no ATG, no cyclosporine, no transplants. We had no, I mean, even I'm not supposed to say we because I was a kid and wasn't in medicine. But the only thing they had was androgen, and so there were some clinical trials. As you see, not many people survived. I mean, the prognosis of severe aplastic anemia dramatically improved. About 10% was alive after 1 year since diagnosis back in time. It is totally opposite. Maybe 10% may still pass away from aplastic after 1 year, but over 90% are surviving from the diagnosis at that point. Now, this isn't an easy disease because there wasn't anything to study inside the bone marrow, and I can only imagine how difficult it was to look into what's not there. Now, the clues for this diagnosis of the pathophysiology came from attempts to save with a transplantation. And this is one of the earlier studies actually with syngeneic donor transplant. So if you have aplastic anemia and happen to have genetically identical twin, this is a study from Fred Hutchinson that they just dumped in bone marrow cell from the donor. And it's very illustrating that half the patients recover the blood counts, but half didn't. So it's a kind of gives us a mixed picture that there is something more than just being empty that is preventing the donor cells from growing. But still, I think some of these patients did recover by the cells alone. Another clue was, when early days, people are trying to infuse sort of mismatch whatever the bone marrow cells, and most of them rejected the cells after transplant attempt. So donor cell did not come back, but the patient's own cells started to come back after 2-3 months from these processes, often using ATG or immunosuppressive drugs. So that was one of the first clues that this may be a kind of autoimmune or immune-mediated processes. And since then, I think, again, I think Dr. Paquet reviewed, but immunosuppressive therapies have been extremely successful, and I'm just showing some of the evolutions over time. ATG cyclosporine had become pretty much standard by late 90s through 2010, etc. Until another study came up from the NIH group adding L-Trombopag improved response rate from previous 60-70%, now up to 80-90%. A little faster improvement. And this cohort, I mean, 97% was surviving after 2 years. And this is a long-term follow-up survival curve. So this is what kind of prognosis nowadays aplastic anemia patients have without a transplant. Now, however, they are surviving, but with some issues. And one of them is a chrono evolution. I think you probably heard from one of our patients just shared her story about. So again, I'm not supposed to be talking about the individual patients. I'm not going to talk. But I think we see often that patients who are treated with ATG can evolve some different bone marrow disease, PNH or MDS, or recurrent cytopenia happens as well. The left side is a very old observations. Right side is trying to say, even with a clonal hematopoiesis, not everything is the same in terms of the risk for progression or life. Trisomy 8 seems to be okay, but monosomy 7 is really bad. And the NIH group had some updates, and adding eltrombopag did not really change the way that mutation evolves. Again, about 10% of them, or relapse happens when they stop immunosuppressive medications. So nowadays, upfront transplant we do, but also we have many patients who are survivors of aplastic anemia, often childhood, 5 years, 10 years later, still some dealing with on and off low blood counts or concerns about clonal evolutions, and then they come to us for a bone marrow transplantation at that stage. And that will be a very nuanced discussion because those patients are often not life-threatened. They're okay in terms of not having serious life-threatening condition, but living with medical issues, debilitations that transplant can often cure. Mobility issues. Now, how is transplant doing? It's great too. And, younger patients, 90% plus are being cured successfully. Older patients now for aplastic anemia, the median age of transplant or onset is around 18 to 20. So, over 20-year-olds tends to be called old for this, very different from MDS. And slightly, still challenging. And I'll show you some other data. Older adults, aplastic remains unmet clinical needs right now. Now, we did have a kind of pilot study looking at the outcomes of survivors after. So we kind of see what happens from the time of transplant or from the time of ATG. But what about people who survived at least 1 year, and how they do, surviving patients? And we had two transplant and non-transplant, and I would skip through. Actually, this is a bottom line that. So compared to people age adjusted and race adjusted, people on the street, even after surviving, 1 year, they do have some life risk due to infections or complications after ATG or transplants. But for those who are doing okay, 5 years, that point, the mortality risk is very much, back to anybody else in the community. And I think we'll kind of talked about this. So the decision for transplant in aplastic anemia is relatively more complex, and I'll talk to you. Let me see if I do this. Yeah, this is a kind of schema that it's a little more complex. That both ATG and the transplant works well, and which to do first is very nuanced. Like we often use age as a criteria just because the transplant outcomes are still a little more challenged in patients who are like 40, 60 years kind of range, whereas the kids, young adults do very well. So we tend to consider transplant for younger patients, ATG for older people. Also sort of, donor may not be immediately available, many of the patients. So if you don't have a matched sibling donor available, we often start off with ATG, and keep looking for a donor. And when you have a donor, by that time, if you're responding to ATG, then may not need to proceed. Some of these paradigms been actively studied. There are a couple of national studies going on to compare upfront versus upfront transplant versus ATG in pediatrics, and upfront transplant study for adults. Um, Now, I think maybe I have only a few minutes left. So again, not to go to details of how to transplant, uh, um, but again, we had some challenges in outcomes in donors who are not fully matched in the past. And these are the data indicating that, but the outcome using not perfectly matched donor, such as mismatched unrelated donor or so-called haploidentical donor who is half match family members. The results are really catching up, and some studies very similar outcomes. I mean, overall survival wasn't very different in MDS actually. Also, so-called relapse-free survival was slightly inferior still. How to transplant involves how much chemo, how much radiation, intensity of the regimen. And it is, again, understood and believed that the more higher intensity we use, the lower risk of recurrence of MDS. However, the trade-off is that the higher intensity we offer, the more toxicities and therefore side effects and complications that could potentially be life-threatening. So again, it is a very fine tuning that we do in transplant programs according to each patient's health conditions and how aggressive the MDS may be, looking into molecular markers and chromosome changes too. Again, the GVHD will be discussed later this afternoon, so I'm not gonna go too much details, but just so you know, a procedure called post-transplant cyclophosphamide has been quite successful, especially when the donor is not perfectly matched. And so you'll be hearing more about this method. And we have sort of just like we look at the mutations and so forth for MDS, we also try to understand the health condition of the patients to estimate, I mean, how much chemo they can take, whether they can go through the transplant processes. And there are lots of items we go through to make index for comorbidity. Or now for older adults, we have functional assessments that tell us resiliency, so robustness of the health condition. And that this is kind of the schema that we go through the decision-making processes. Now, transplant for severe aplastic anemia, as I mentioned, the donor matters. Bone marrow graft has been historically producing better results than peripheral blood stem cells for this disease. And the graft versus host disease prevention, similar to what I talked to you in MDS, that the post-transplant cyclophosphamide has also been increasingly used for this diagnosis and offering access to transplant in more patients. These are some of the the data that nationally we conducted. It's a rare disease, so single center is very hard to do these cooperative group studies. I think this is a summary. We see improvement in non-transplant therapy and the transplant therapy in both MDS and aplastic anemia actually. So the decision-making process about who to transplant, when to transplant, often come down to really individual discussions and not a single time. It often kind of discuss over the course of medical management, that very dynamic process. Nonetheless, I mean, all of these risk assessments improved access to transplantation. And again, I think, this talk is meant to discuss how we discuss transplant as opposed to how we, let's say, technically, how we do transplants, and we'll have to leave some of the details of transplant methodologies today. I'd like to thank you, everyone. This is transplant reunion that is scheduled on May 3rd on this campus. Patients and family gather, and just like you today, really, inspires staff, providers, and it's a great way to appreciate the partnership actually that patients and family have with what we do. So thank you so much, and I'd like to take any questions.
Very thorough. Thank you.
All right. Okay. Thank you.
Thank you so much, Dr. Nakamura, for sharing your time and expertise with us today.